You mentioned the Hickey protocol for the MRV. What about the transcranial ultrasound and the reflex in the deep cerebral veins?
You could do that. We don't employ transcranial ultrasound. We rely pretty exclusively on the Hickey MRI because it shows us the very subtle flow abnormalities in all the veins. It also shows us iron deposition, at least at baseline, which may or may not be a good marker for future progress or drug treatment or intervention. It also gives us a very good roadmap for all of the veins in the head, neck, and chest. And this serves to make the treatments more efficacious and often safer. They'll often lead us to a different point of entry. For instance, if the azygos has a certain appearance, we'll often enter through a vein in your arm as opposed to a vein in your leg because it turns out it's easier to treat that way.
Yeah, someone else's turn. Thank you.
I just wanted to say something too. Dr. Hewitt is going to be sticking around after the question and answer period, so there are very specific questions he would be willing to speak with you after, just so we can get around to a lot of the questions in the audience.
I have a question for Dr. Hewitt. How do you determine what the normal venous flow is? And you mentioned many times that it's returned to normal, but how can you determine what the normal is?
I like to use the word homeostatic. You know, normal is going to be different for everybody, but after doing this for so long, you get a really good feeling what normal venous blood flow is going to look like in any given vein.
Just wondering, how often can you re-intervene before you can't do it anymore?
Hopefully as little as necessary. Obviously, I don't think there's any maximum number of times you could re-intervene. We like to talk about restenosis. I think our main job as interventionists, people who treat this disorder, is to try and obtain a result that prevents restenosis for as long as possible. Most people will restenose at some point, and it's very individualistic. For some it might be 8 months, for some it might be 10 years. I don't think any physician can look you in the eye right now and give you a good idea how long it's going to be before you possibly restenose. What I can do is I can look you in the eye and I can tell you that I'm going to do the very best possible job and swing the odds in your favor so that you have the best chance of remaining patent for as long as possible.
My question is for Dr. Code. Dr. Code, you made a comment earlier about yourself saying that you had a high iron content, or I can't remember the exact term. Is that something beyond CCSVI? Is that also something like hemochromatosis?
No, it's a good question. Hemochromatosis is a small percentage of people, maybe 1 in 300, have the inability to get rid of iron in the body. So we typically bleed them every week or two to treat that. Although some people are also now using a form of oral chelation to reduce that iron. Now, the iron I spoke of in myself, of course, is related to the particular MRI that they used in Buffalo, which they also use in the Hickey MRI that Dr. Hewitt talked about. But it is confirming that almost everyone that has the excess, or that has CCSVI, has excess iron in the brain. I have much more than average. Maybe that's because it's 12 years, although I've probably got 20 years of symptoms, maybe 30 of symptoms, probably 30 years of symptoms, because I had my first symptoms probably at 26, 27, now 57. And it's going to be another important part of the puzzle, I believe, is how can we minimize that iron and how can we help some of it go away once we take the problem away, okay? So it's a whole different step for us. And I also alluded to there may be other neurologic ailments that excess iron is a problem. We have known with MS for more than 100 years that folks with MS at autopsy have more than average iron in the brain. We've also known for more than 100 years that people with their MS lesions in the brain are centered by a vein. Okay, so it all fits and ties together very much. And so part of my own personal journey, and I hope to find more, research and protocols for it, is to how can you minimize the iron? Because the iron causes lots of antioxidant requiring problems. It creates free radicals in the brain, it injures the brain, which is the prototype of almost every injury in the brain that's chronic. So it happens in Alzheimer's, it happens in Parkinson's, it happens in MS, and it happens post-stroke. Maybe, just maybe, that's one of the reasons I've done as well as I have, because I've really leaned on that sort of antioxidant approach, to minimize the progress, even though, lots of iron there.
Question in the middle.
The gentleman on the panel, do you support the use of pharmaceutical iron thinners either before, during, or after getting venous angioplasty procedure done, or can this also be done through diet of low cholesterol foods, such similar to a heart valve in a heart attack patient?
So I think what you're meaning is blood thinner as opposed to iron thinner, correct? Yes, blood thinner. So I'm gonna have Dr. Hewitt respond to that. There is, a component that you can do with diet. And the more omega-3s, I take a large amount of fish oil, and I know that reduces the clotability within my blood. I also know, because I'm booked for a couple of weeks in Dr. Hewitt's facility, that I must not take the aspirin group of drugs for at least 3 days prior to. And then I'm going to let him answer the other piece, but, I've seen many, many patients now that don't want to take warfarin for their atrial fibrillation or other problem. Some of them cannot tolerate it. So those folks do pretty well on large amounts of fish oil plus aspirin. But now we're into a special field, especially if there's a stint involved. I'm going to let Dr. Hewitt answer that part.
Anticoagulation, we get a lot of questions about this. I would phrase my answer by saying the most important thing here is flow, is the angioplasty that we do to restore a normal flow. For our patients who have a very good flow after we performed the angioplasty and made the vessel look as good as we can, we put them on a short course of anticoagulation. There are patients that we perform angioplasty and we do whatever we can to get that vessel looking as perfect as possible, and the flow still isn't quite to our satisfaction. And those patients we're going to give a longer course of anticoagulation to give them every possible benefit. Now, having said that, even those patients that have good flow, the anticoagulation may be superfluous. We like to give it just as an extra insurance policy to try and make sure that the vessel stays open.
I just want to ask include one other piece, because we know enough about scarring and healing, whether it's a surgical scar or an induced, injury to the vessel by dilating it. We know enough that if you do enough important things in your diet and the foods that you take in, you can reduce the likelihood of a scar. Okay, so that really matters too, and that will be my long-term plan, and myself and others that I suggested to really focus on that healthy pieces of the diet to optimize healing and minimize scar formation.
Oh, my question is what adverse conditions or complications can arise out of having the angioplasty done? Maybe life-threatening or whatever it might be.
The procedure itself is very, very safe procedure. Venous angioplasty, the veins are a low-pressure blood system. Whenever we do a medical procedure, we like to talk about things like bleeding and infection. We're piercing the skin, so there's always a risk of bleeding. There's always a risk of infection. That's why we do these in a hospital or a sterile facility and not the street corner. Or the beach, correct? Sand in your veins is not good for them. In disrupting the valve or opening up the stenosis, we occasionally will get a leakage of blood outside that vessel. We can quite quickly attain hemostasis. In other words, it seals closed and there's no more bleeding. I'd like to make the clear distinction to all of you dealing with arteries and veins. When we deal with arteries, it's a much more sensitive situation. Lots more problems with bleeding. significant complications. With the veins, the risks are much less.
There's a lady here. Okay, why don't you go ahead while she's getting the mic?
I'll address this to Dr. Wood. No one here has mentioned CAN work, but some of us here probably can't work anymore, and this is a significant cost. I'm not going to ask you for dollars and figures, and all of us are searching the internet. There seems to be an amount that's fairly common across the board. It doesn't even matter which countries we're looking at, which groups there are, minor variances. Speaking of re-interventions, though, are such things also a la carte? For instance, if you've done a balloon angioplasty and a stent, and you've done it right, but the person still gets restenosis due to, say, thrombosis, let's say, is that another, I can't remember what it is, something like $7,000 procedure to go back and go around it again?
In our clinic, it varies depending on where it was done. Our goal in our clinic is to try and, we don't like to, this is difficult for people.
I know, because some of the problems I've already seen where there are comments about if you go to that particular clinic, you charge for each balloon, each stent, each injection, anesthetic, and each white.
That's what we've tried to avoid in particular. Speaking for our clinic alone, there's very upfront costs that try to include everything. The re-interventions, sometimes they tend to be much more difficult, take much longer, and involve a lot more equipment, and they can be more expensive.
Thank you. First of all, I'd like to thank Cheryl and all the speakers tonight for holding this meeting and for speaking to us. I appreciate it very much. I'm totally convinced that this is the treatment that I need, and I will be arranging it tomorrow if I can. But I have some questions about restenosis, and I was interested in your comment, Dr. Hewitt. And I actually have a friend of a friend who had treatment from you, and he's doing exceedingly well, so that's good. My question about the restenosis is, does this happen on the table? Like while you're there, does the balloon open the vein, and then sometimes you can see, in a few minutes that it's not working, and you keep doing it again? Like, I don't have a good idea of how long you lie on the table and have the work done initially. And my question then is, do you often see a problem right then and there, and you do it again until it's working? And what is the average time that a person would be getting treatment? Thank you.
For someone who has not been treated before, a typical treatment time is about 1 hour to 2 hours. Okay, that's a simple answer for you. Restenosis is a more difficult answer. When we talk about restenosis, most of us are usually referring to something that occurs months to years later. Okay, so if you heard the term restenosis, we're not talking about something that occurs on the table. If it occurs on the table, we're going to angioplasty it again. If it occurs again, we're going to angioplasty it again. Maybe hold that balloon up a little bit longer. And try to do whatever we can with an angioplasty. In our clinic, we try to do whatever we can in general to avoid putting a stent in. But in some cases, if that stenosis will not stay open after numerous angioplasties, stent placement will be required. It's just important to put a large enough stent so that we don't have problems later on. There are also some patterns where we look at your MRI and we can tell you that more than likely you will need a stent. For instance, someone who has a jugular stenosis all the way from their skull base down to their chest, in general, those lesions do not stay open with angioplasty alone and may likely require a stent.